Hello everyone. Welcome to the YouTube channel of Shree Swaminarayan Physiotherapy College, Ahmedabad. Myself Dr. Khyati Mewada, lecturer at Shree Swaminarayan Physiotherapy College. Today we are going to learn about the assessment of the shoulder pain. Our assessment consists of the subjective part and the objective part. The subjective part consists of the demographic data of the patient, history of the patient, and the pain assessment in our orthopedic assessment. The objective portion consists of the observation, palpation, and examination. One of the important factor in the assessment is patient's age. Age can tell you what could be the underlying pathology your patient is suffering from. For example, if the patient is between 40 to 60 years of age, there are high chances of the degeneration going on. So it could be a rotator cuff degeneration as well. Along with the rotator cuff degeneration, there are also chances of the shoulder joint arthritis. If your patient is of the rotator cuff tear, it can occur at any age due to any of the overuse activity or any sudden activity as well. If your patient is coming between 45 to 60 years of age, there could be chances of the frozen shoulder. If your patient is older than 35 years of age, chances of primary impingement also increases. For the secondary impingement, there has to be some other primary pathology which leads to the secondary impingement, which can occur in the late teens or the 20s as well. Next, we have the mechanism of injury. Now, in the shoulder joint, the mechanism of injury could be an sudden or an overuse injuries. For the sudden injuries, there is a push injury which can lead to the fracture or dislocation of the shoulder joint. If there is a history of sudden fall on the side of the shoulder or receiving a direct blow to the tip of the shoulder, chances of acromioclavicular joint injuries are also increased, like dislocation or subluxation. Here, as we are looking at the shoulder joint is not just a single joint. It is a complex. The shoulder girdle is an entire complex which consists of your glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic joint. So, don't miss out on the AC joint, SC joint, and the scapulothoracic as well. Next up, we have the overuse injuries, which consist of a very gradual mechanism of injury. Now, if any movement or position causes the patient pain or symptoms, so if we correlate with the pathologies or the conditions, if your patient is having recurrent dislocation or instability of the shoulder, then any movement involving to the specific instability can bother the patient. For example, in the case of anterior instability, movements involving the lateral rotation with abduction can bother your patient. In the case of rotator cuff tear, there patient could be having night pain or pain at rest as well, which can also occur occasionally in the case of tumors around the glenohumeral joint. If your patient is having any inflammation like peritendinitis, then activity related pain usually signifies that. If your patient is having arthritic pain, the patient could be having pain at the extremes of the glenohumeral range of motion. Next up, we have the acromioclavicular pain. Greater than 90 degree of abduction, or mostly almost at the extreme of the abduction, your patient will be having a localized pain to the acromioclavicular joint. Any activities which can increase the pain. Here we are discussing about the aggravating factors and the relieving factors for the pain. So if your patient is having instability or inflammatory condition, lifting the arm over the head usually exacerbates the shoulder problems. Any position or anything like rest or any non-inflammatory drugs, cryotherapy, or anything which relieves the pain to the patient can be mentioned in your pain assessment and can also give you a certain idea about the ongoing pathology. The extent and behavior of the patient's pain, which also means the type of pain the patient is having. So if the patient is having strain of the rotator cuff, for example, your patient might complain of a dull aching pain as well. If your patient is having any acute calcific tendinitis, for example, your patient might tell you he or she is having hot burning type of pain. Okay, so now till here we discussed about the pain history of the patient. How can you correlate with the presentation of the patient? Now we can discuss about the common pathologies which we encountered in the clinic and how you can rule out the possible pathology. Okay, so first of all, we can also rule out from the painful arc syndrome how to rule out the pathology. So, in the painful arc syndrome, if you ask the patient to abduct the shoulder joint from 0 degrees to 180 degrees, right? If your patient is having no pain from 0 degree to almost 45 to 60 degree, then your patient complains of pain from 45 to 60 degree to 120 degree of abduction. After 120 degree of abduction, when the pain goes away again, then it can signify that your patient is having glenohumeral painful arc, which can also be due to the subacromial impingement syndrome as well. Now, this was about the glenohumeral joint. If your patient in the painful arc is complaining of the pain at the end of the abduction from almost 170 to 180 degree, then it could also be the affection of the acromioclavicular joint. Okay, so here is a list of the common pathology of the shoulder joint and how you can put it in the differential diagnosis and how to reach a diagnosis for that. Here they have mentioned the cervical spondylosis too, cause any affection of the cervical spine can also mimic a shoulder pain as well. So you have to correlate it properly depending on the patient's symptom. In the cervical spine patient, you have to screen the shoulder. In the shoulder pain patient, you have to screen the cervical spine. It goes like that. So if we come to the history portion, in the rotator cuff lesion, frozen shoulder, atraumatic instability, the history portion, as we discussed priorly, that between it generally occurs between the age of 30 to 50 years of age. Frozen shoulder generally occurs 45 plus, and atraumatic instability can occur between the age of 10 to 35. Pain and weakness after the eccentric load can occur in the rotator cuff lesions. Frozen shoulder is generally has an insidious onset or can occur after the trauma or surgery. Atraumatic instability, pain and instability can occur with the activity for the patient. Whereas in the case of cervical spondylosis, spondylosis again is a degenerative condition, so it occurs after the 50 years of age commonly. Now coming to the observation portion, for the rotator cuff lesion, okay, as we come to the observation, on observation, mostly in the case of rotator cuff, frozen shoulder, atraumatic instability, mostly it would be normal bone and soft tissue outlines. In the case of cervical spondylosis, if we observe the cervical spine, there could be minimal to no cervical spine motion or torticollis can be present. Coming to the range of motion, in active motion, rotator cuff lesion affects the muscles of the rotator cuff surrounding the shoulder joint. So there could be weakness of the abduction and or rotation or both, right? Crepitus can be present. In the case of frozen shoulder, the shoulder will be having restricted range of motion. In the case of instability, there could be full or excessive range of motion. See, there is a difference. In the case of instability, the range of motion could be hypermobile. In the case of frozen shoulder, it could be hypomobile. And in the case of the rotator cuff lesions, the weakness could be present along with the restriction of the range of motion. In the case of passive movement, rotator cuff lesions, pain if impingement occurs. In the case of frozen shoulder, there would be limitation in the range of motion, but the characteristic feature is the presence of the capsular pattern of restriction, which is lateral rotation, abduction, and medial rotation for the shoulder joint. In the case of instability, atraumatic instability, passive motion again would be normal or excessive. In the case of cervical spondylosis, here they have mentioned limited range of motion with pain, but it is in relation to the cervical spine and not the shoulder joint. Okay, so coming to the other portion of the assessment for your differential diagnosis, next is the resisted isometric motion. Next is the resisted isometric motion. Resisted isometric motion tests your contractile structures. So, in the case of rotator cuff lesion, the muscles are at fault. That means the contractile structure is at fault, so there would be pain and weakness on abduction and lateral rotation. In frozen shoulder, resisted isometric will be normal when the arm is by the side. In traumatic instability, again it would be normal. Coming to the special test, for the rotator cuff lesion, there are certain tests which could be positive, special test which coming to the special test for the rotator cuff lesion, drop arm test can be positive, empty can test will be positive. Frozen shoulder, there is no special test to diagnose the frozen shoulder. For the atraumatic instability, load and shift test, apprehension test, relocation test, augmentation test will be positive. In the case of cervical spondylosis, again they are referring to the cervical spine special test. So Sperling's test, distraction test, ULNT test, shoulder abduction test will be positive related to the neurological symptoms. When we come to the sensory functions and reflexes, in the case of rotator cuff lesions, again it won't be affected. Frozen shoulder not affected. Atraumatic instability, if the instability hampers the neurological structures, there could be affection. Cervical spondylosis, definitely if the nerve roots are affected, dermatomes will be affected, reflexes will be affected. On palpation for the rotator cuff lesion, it would be tenderness. There would be tenderness over the rotator cuff. Frozen shoulder, not painful unless capsule is stretched. Atraumatic instability, anterior or posterior pain. Now coming to the radiology portion. In the case of rotator cuff lesion, on radiograph, upward displacement of the humeral head will be seen or acromial spurring. MRI again is a very diagnostic tool for the muscle lesions. Frozen shoulder, radiography, it would be negative. Arthrography, there could be decrease in the capsular size. Atraumatic instability, if it is atraumatic instability, it would be negative. But if the patient is coming with a traumatic dislocation of the shoulder joint, definitely the radiograph would be diagnostic. For the cervical spondylosis, definitely radiograph will show the sign of the degeneration. Thank you for listening to this video. The reference for the current video is Orthopedic Physical Assessment David J. Magee 6th edition. Thank you very much for listening to this lecture. Don't forget to like, share and subscribe to our channel.